Hello everyone and welcome to our module on myeloproliferative disorders. Myeloproliferative disorders, as the name implies, are disorders where there is proliferation or excess production of cells of the myeloid lineage. So cells of the myeloid lineage include granulocytes, red cells, and platelets. So in many cases of myeloproliferative disorders, what this means is there will be an increased number of peripheral cells of a particular myeloid type. For example, chronic myeloid leukemia is a type of myeloproliferative disorder, and there are excess granulocytes in the peripheral blood in this condition. In essential thrombocytosis, there are excess platelets, and in polycythemia vera, there are excess red blood cells. Listed on this slide are the four major types of myeloproliferative disorders, and an easy way to think of each of these is that in each disorder, something in the bone marrow is overproduced. In CML, granulocytes are overproduced from the bone marrow. In essential thrombocytosis, it's platelets. In polycythemia vera, it's red cells. And in myelofibrosis, which is a little bit different from the others, there's overproduction in the bone marrow of fibrous tissue. What's unique about this condition is that it leads to low peripheral cell counts, and we'll talk more about that later in this video. Each of the four major types of myeloproliferative disorders has a characteristic genetic abnormality associated with the condition. In the case of CML, the genetic abnormality is the Philadelphia chromosome, and I talk about this in detail in the module on chronic leukemias. For the other three myeloproliferative disorders, the genetic abnormality associated with each of them is called a JAK2 mutation. This is found in almost all cases of polycythemia vera and the majority of cases of essential thrombocytosis and myelofibrosis. JAK2 is a gene for a tyrosine kinase enzyme that's found in the cytoplasm of cells. The JAK2 gene is located on chromosome 9, and mutation of this gene leads to excessive tyrosine phosphorylation. The implication of this for progenitor cells in the bone marrow is that they become hypersensitive to cytokines. Thus, they grow more and they live longer, and this is what leads to excessive myeloid proliferation. Now let's begin our discussion of specific types of myeloproliferative disorders, and we'll start by talking about polycythemia vera. The definition of polycythemia vera is an elevated red blood cell mass. Now, we don't normally measure the mass of red blood cells in the plasma, but we do routinely measure the hemoglobin and hematocrit. So I've shown you on the screen a patient with a normal hemoglobin and hematocrit like 15 and 45, and the types of numbers you might see in a patient with polycythemia vera. So for example, a patient with P vera could have a hemoglobin as high as 20 or a hematocrit as high as 60. To make the diagnosis of polycythemia vera, you have to exclude that the patient has a high erythropoietin level. If the level of EPO is high, that's going to lead to polycythemia, but that's not polycythemia vera. That's called secondary polycythemia when the cause is a high EPO level. In polycythemia vera, it's a bone marrow process of overproduction of red cells. So the body responds to this by lowering the EPO level. So if the patient has polycythemia vera, the EPO level should be low. For patients who have polycythemia and a high EPO level, there are two classic causes. The first is chronic hypoxemia from lung disease. Patients with chronic lung disease commonly have an increased red cell mass and a high hematocrit. It's because their body is responding to hypoxemia by raising the EPO level. You can also see polycythemia secondary to an EPO-secreting tumor. The two classic tumors to do this are renal cell carcinoma and hepatocellular carcinoma. So if you look at this table at the bottom of the screen, hypoxemia, tumors, and polycythemia vera can all cause an increased red cell mass. But you can differentiate them by measuring the PaO2 on a blood gas and the EPO level. For patients with chronic lung disease and hypoxemia, the PaO2 will be low and the EPO level will be high. For patients with an EPO-secreting tumor like renal cell carcinoma or hepatocellular carcinoma, the PaO2 should be normal, but the EPO level will be high. And then if the patient has polycythemia vera, the PaO2 will also be normal, but the EPO level will be low. So this is an essential part of the workup of polycythemia vera, measurement of the serum EPO level. There are two basic mechanisms that underlie most of the symptoms of polycythemia vera. The first one is an increased red blood cell mass. This leads to an increase in blood volume. Patients with polycythemia vera have a higher blood volume compared to normal patients. This causes hypertension and it can cause flushing of the skin. The second mechanism is thrombosis. When you have an increased number of red cells, the viscosity of blood is increased. Recall from Poiseuille's law, which I discuss in the cardiology section, that the resistance to flow through a vessel is proportional to the viscosity of the fluid. So when viscosity goes up from an increased red blood cell mass, that means resistance to flow goes up. And when resistance to flow goes up, blood flow can become slower, and slow blood flow is stasis of blood, and that's a setup for thrombosis, which occurs with greater frequency in patients who have polycythemia vera. In addition, along with the increased red blood cell mass, there is sometimes also an increased platelet count, and this also predisposes to thrombosis. Now that we understand that, we can talk about some of the symptoms of polycythemia vera. First of all, many patients are diagnosed when they are asymptomatic. A routine blood test is performed, and this identifies the presence of increased red blood cells. When patients do have symptoms, there are lots of potential symptoms that can develop. You can read about all of these, but I've listed some of the key ones on this slide here. First of all, the skin can look red and puffy. Remember, there is an increase in blood volume, and this can lead to this finding. Sometimes this is described as facial plethora because the face is swollen and red-colored. Another classic symptom is called aquagenic pruritus. This is unbearable itching after a warm bath or shower. The mechanism of this is not entirely clear. It's believed to involve histamine release and prostaglandins, but nevertheless, it is a classic presenting symptom of polycythemia vera and one you definitely want to know for your boards. Another classic condition to develop as a result of P. vera is deep vein thrombosis, especially Budd-Chiari syndrome, which is a blood clot in the hepatic vein. In fact, if a patient presents with an unexplained Budd-Chiari syndrome, one of the things you have to think about is that that patient may have polycythemia vera. Polycythemia vera can be treated with regular phlebotomy. This reduces the red blood cell mass. It's also sometimes treated with hydroxyurea. I talk about this drug in the biochemistry section. It inhibits ribonucleotide reductase. This is the enzyme that converts RNA nucleotides into DNA nucleotides. When it becomes inhibited, it blocks the formation of deoxynucleotides, which are necessary for synthesizing DNA. This inhibits the replication of those progenitor cells in the bone marrow and leads to a reduction in red blood cell mass. There are a number of complications of polycythemia you should know about. The first one is progression to the spent phase. This happens in about 15% of patients. The excessive replication of progenitor cells in P. vera leads to the bone marrow becoming burned out. It develops fibrous tissue filling up the bone marrow. This is called myelofibrosis, and this leads to bone marrow failure. Another potential complication is leukemia. Remember that polycythemia vera is a malignancy of myeloid cells, so it's easy to understand how it could in some cases progress to a myeloid leukemia. Usually this is acute myeloid leukemia, but sometimes it's chronic myeloid leukemia. And then finally, gout can happen to patients who have polycythemia vera. There's lots of DNA turnover from the increased red blood cell production in the bone marrow. This leads to increased purine metabolism. In the biochemistry section, I talk about how purines are metabolized into uric acid, and when you have high uric acid levels, you can develop gout. This also happens in other myeloproliferative disorders as well, including CML. Our next disorder is the least common of the major myeloproliferative disorders. It's called essential thrombocytosis, also sometimes called essential thrombocythemia. Just like polycythemia vera, this is a malignant proliferation of myeloid cells. However, in this case, the condition predominantly affects megakaryocytes and platelets, and the hallmark of this condition is an elevated platelet count. Essential thrombocytosis is considered a diagnosis of exclusion. This means you need to exclude other causes of a high platelet count in order to diagnose this condition. So first of all, you have to exclude other myeloproliferative disorders. In CML and polycythemia vera, you can see a high platelet count, and you need to exclude those conditions to diagnose essential thrombocytosis. In addition, you have to exclude what's known as a reactive thrombocytosis. This is a rise in the platelet count reactive to some other medical condition. So what are some other conditions that can trigger a rise in the platelet count? Well, first of all, you can see increased platelets in the setting of iron deficiency anemia. The mechanism of this is not well understood, but it's believed to have evolved to protect against blood loss. When iron levels are low, the body interprets that as a loss of blood, and it raises the platelet counts to try and prevent blood loss. You can also see a rise in the platelet count in other settings of blood loss like acute bleeding or hemolysis. Infections or inflammation can also raise the platelet count, and finally cancers, especially metastatic cancers, can be associated with a rise in the platelet count. So key blood tests when you think a patient might have essential thrombocytosis include measurement of the red cell count, obviously to exclude anemia, and also tests for acute phase reactants. So if the C-reactive protein level or the fibrinogen level or the SED rate or the ferritin level are increased, this suggests some occult inflammatory process driving the rise in the platelet count. The symptoms of this disorder are very straightforward. Basically, although there is an increase in platelet count, they don't function normally, so you can have bleeding from poor platelet function, and you can also have thrombosis from overactivity of platelets. The prognosis of this condition is generally good. Most patients have no disease-related complications and require no treatment. The complications we talked about for polycythemia vera, like leukemia and myelofibrosis and hyperuricemia, are all very unusual in this myeloproliferative disorder. Occasionally, patients who are high risk, usually meaning patients with very high platelet counts or a history of thrombosis, are treated, and they can be treated with hydroxyurea, just like we talked about for P. vera, and they can also be treated with aspirin, which inhibits platelet function. Our next myeloproliferative disorder is myelofibrosis. So first let's define a couple terms. When we say a patient has primary myelofibrosis, this means they have a myeloproliferative disorder where fibrous tissue is overtaking the bone marrow. When we say a patient has secondary myelofibrosis, this means they have developed myelofibrosis secondary to another condition. We talked about how this can happen in the spent phase of polycythemia vera. It can also be seen in patients with chronic leukemias and sometimes patients with other conditions. So primary myelofibrosis is the topic for this module. It is a myeloproliferative disorder, and in this disorder there is excess collagen produced from fibroblasts. This leads to marrow fibrosis. Basically, the collagen overtakes the bone marrow and crowds out the normal elements. This leads to pancytopenia. The underlying physiology involves stimulation of fibroblasts by growth factors secreted from megakaryocytes, especially platelet-derived growth factor and transforming growth factor beta. Both PGDF and TGF-beta are released in this condition. They are what trigger the fibroblasts to produce the excess collagen that leads to the myelofibrosis. The pathophysiology of this condition involves two hallmarks. The first is bone marrow failure when the bone marrow is taken over by fibrosis. The second is extramedullary hematopoiesis. When the bone marrow fails, other organs take over the job of the bone marrow and begin performing hematopoiesis. Those organs include the spleen, liver, and the lymph nodes. You can even sometimes see in severe cases hematopoiesis occurring in the central nervous system, the lung, the bladder, even in the skin. The hallmark of this condition is extensive extramedullary hematopoiesis outside of the bone marrow. This is a disease of older patients. The median age of onset is 67, and patients typically present with fatigue, weight loss, and night sweats. These are all symptoms from increased metabolism from extramedullary hematopoiesis. There's also a severe anemia in this condition, and that can lead to fatigue. A characteristic finding on physical exam is massive splenomegaly. This happens because the spleen is the principal site of extramedullary hematopoiesis. This can present as left upper abdominal pain. The spleen can even become so enlarged it can compress the stomach and cause early satiety. You can also see enlargement of other organ systems involved in extramedullary hematopoiesis, including the liver and the lymph nodes. The characteristic finding on peripheral blood smear is called leukoerythroblastosis. This is a finding that occurs when there is inappropriate release of cells from the bone marrow, especially precursor cells. So in the peripheral blood of patients with myelofibrosis, you can see immature erythroid and granulocyte precursors. This is called leukoerythroblastosis. These are being pushed out of the marrow by the fibrosis. They're also being produced by organs where extramedullary hematopoiesis is occurring. There's usually a severe anemia in patients with myelofibrosis. It's a normocytic normochromic anemia. The hemoglobin can get very low, often less than 10. The white blood cell count and the platelet count are variable. They can be elevated, normal, or reduced depending upon the degree of extramedullary hematopoiesis. Immature neutrophils are often seen, and other immature forms like myeloblasts can also be seen. Gout can occur in primary myelofibrosis. There's high cell turnover due to extramedullary hematopoiesis. This leads to excess purines, and purine breakdown leads to gout, just like we talked about previously. And the treatment for primary myelofibrosis is a stem cell transplant. In addition to leukoerythroblastosis, which I mentioned before, the other classic finding in myelofibrosis on a peripheral blood smear is the presence of teardrop cells, which are also called dacrocytes. These are red blood cells that have been deformed as they leave the fibrotic marrow, and this is an example of a teardrop cell shown in the screen here. It's characteristic of myelofibrosis. I'm going to finish this module by talking about a rare set of disorders known as Langerhans cell histiocytosis. These disorders are very uncommon, but they do come up on the Step 1 exam. You may get a question or two on these conditions, and you just need to remember a couple of things about these disorders to get the questions right. So we'll go over these in the next few slides. So a histiocyte is a connective tissue macrophage. Therefore, a histiocytosis is a proliferation of histiocytes. And a Langerhans cell is a type of histiocyte. It's also a type of dendritic cells. And I talk about dendritic cells in the module on the innate immune system in the immunology section. They're common in the skin and connective tissue. They consume antigens peripherally and then migrate to lymph nodes. And once they reach the lymph nodes, they are professional antigen presenters where they activate T cells. This disorder is a clonal proliferation of dendritic cells, those professional antigen presenting cells we talked about on the last slide. And it's called Langerhans cell histiocytosis because it was once believed that Langerhans cells of the skin were the malignant cells in this disorder. It turns out the malignant cells are actually precursor cells of myeloid origin, but nevertheless they express markers that are usually found on Langerhans cells.
Those markers include CD1A, S100, and CD207. These are the same markers you find on Langerhans cells. And so for your board exams, one of the things you want to know about this very rare disorder is that the malignant cells express these surface markers, and if you see a description of these types of markers, it should bring Langerhans cell histiocytosis to mind.
The other thing they will want you to know about the malignant cells in this condition is that they contain Bierbeck granules in their cytoplasm. Bierbeck granules are organelles that look like a tennis racket. There's one shown on the screen here, and they're found in the cytoplasm of normal Langerhans cells and also in the malignant cells in this disorder. And you can't see these under the regular light microscope. To visualize these, you have to use electron microscopy. There are lots of different clinical features that can potentially develop in Langerhans cell histiocytosis, but a couple of key facts you want to remember. The first is that these are largely disorders of children, and although they can involve any organ system, the bone and the skin are common places for involvement in Langerhans cell histiocytosis. Years ago, there were 3 different disorders thought to represent separate conditions, but it's now known that there are 3 different variants of Langerhans cell histiocytosis. But these 3 conditions are still referred to by name because they represent points on a spectrum of severity of Langerhans cell histiocytosis. So the most severe form of the condition is known as Lederer-Sewa disease. The least severe form is called eosinophilic granuloma, and in the middle is Hahn-Schuler-Christian disease. So we'll talk about the symptoms of all 3 forms of Langerhans cell histiocytosis, but it's hard to remember these, and just keep in mind that these all occur in children and they all involve the skin and the bones. The most severe form of the disorder is called Lederer-Sewa disease, and this occurs in very young children, usually about 2 years of age. They develop a diffuse skin rash and cystic bone lesions. It progresses to multi-system failure, and it is rapidly fatal. At the other end of the spectrum is eosinophilic granuloma. This occurs in older children, usually adolescents. There is no skin involvement, only involvement of the bones. For that reason, it often presents as a pathologic bone fracture, and when you see a pathologic bone fracture in an adolescent, you'll often think of some bone tumor like osteosarcoma. But this is not osteosarcoma, and the way you will know that in a board question is because the biopsy specimen will describe features of Langerhans cells and also eosinophils. Eosinophils are often present, and that's why it's called eosinophilic granuloma. In the middle of the spectrum is Hahn-Schuler-Christian disease. This disease involves a triad of lesions in the skull, diabetes insipidus, and exophthalmos. The skull involvement is usually a skin lesion on the scalp. The posterior pituitary is often involved. That's what leads to diabetes insipidus. And finally, the eye socket can be involved. That leads to protrusion of the eye. And I'll just finish with these couple of pictures to help this all stick in your mind. These are taken from a child who had the Hahn-Schuler-Christian variant of Langerhans cell histiocytosis. There's a lesion here in the orbit, which produces exophthalmos. This child has several lesions on his scalp. Remember what I said, that this condition involves the bone and the skin, so it makes sense that there are lesions on the scalp. And that concludes our module on myeloproliferative disorders.